Good afternoon. I have the pleasure of introducing our Grand Round speaker today. I'm Jennifer Hager. I'm a general pediatrician and one of the associate program directors for the Pediatric residency program. Today we have Dr. Megan McCulloch with us. She will be presenting about A Picture's Worth 1,000 Words, or is it? And not only is it a catchy title, but it's a really important subject for us all to be mindful of. Dr. McCulloch received her undergraduate degree in human nutrition, which I happily rely upon in Continuity Clinic to get her advice when we have a patient in need, from Kansas State University, and her undergraduate or her medical degree from the Kansas School of Medicine. She has a passion for patients. She is an empathetic person, not just to our patients and families, but to her colleagues and even her attendings. She excels in patients who need that empathy in Continuity Clinic, but I've heard she's also a pretty cool cucumber in the setting of a cardiac arrest. And she is pursuing a fellowship in critical care medicine and will soon know what her future holds for her. So proud of her accomplishments in and outside of the program, proud of who she is as a person, and thankful that she's going to teach us a little bit more about when to choose imaging and how to choose it wisely. I'll be welcoming her.
Okay, for a person who likes to talk to other people, public speaking is not my favorite activity. So when I was kind of thinking about things to do for grand rounds, I kind of looked into a lot of different things and kind of landed on just really looking at some of the things that we do in medicine that we don't necessarily need to do, but it's become kind of habit to do, and kind of figuring out why do we still do these things? Do we need to still do these things? And how do we best protect the kids that we care for? So for this, we're going to kind of talk about over imaging in general, and kind of in the pediatric population, and then kind of delve a little bit further into some different places that we image a little bit more frequently, that we don't necessarily need to do so. And then we'll kind of talk about some new recommendations with regards to kind of PCARN prediction tools for the new like cervical spine imaging after blunt trauma. So there are a lot of different, as far as like imaging in the pediatric population, we know that it's a lot more complicated and requires a lot more than it does in an adult patient. There is always the possibility of false positives, and you can have that kind of cascade of care where they end up getting a lot of additional studies and a lot of additional treatments and things that aren't necessarily recommended because of incidental findings or things that aren't actually clinically relevant to the kid's case. And then on top of that, with the repeat procedures and things like that, it increases just the struggles that kids have from that standpoint. A lot of kids need sedation. While like serious events in sedation are pretty uncommon, there's always, as we know, the risk of respiratory depression. The kids will sometimes wake up vomiting, agitated, things like that. And then we always worry about repeat sedation, and especially in our chronic kiddos, with regards to like their impact on brain development. With dedicated imaging protocols, kids are smaller, obviously. And so a lot of times at adult centers that do adult and pediatric imaging, a lot of times they don't necessarily follow the pediatric dose relationship with radiation. And a lot of times pediatric places do a lot better, obviously, with following those pediatric protocols to really limit that radiation dose. And so that's something that we struggle a little bit more with, especially in like combination centers. We know, especially from the number of people that are involved for a kid to get an image, we have child life that goes and nurse that goes and CT technologists and the physician that goes if they need general anesthesia. So there's generally just a lot more people that are involved. And that takes kind of time and resources from other places in the hospital as well. And then really the expertise on evaluating images, as a lot of the residents know, we will get like a read back in the middle of the night from VRAD, and then we will get the same image read back from Dr. Du Bois and Dr. Dufek that are a completely different read based on the fact that they look at pediatric images all the time. And so a lot of times when we have our adult radiologies reading these images, it doesn't always match the picture. And so having those pediatric radiologists read those images is really, really helpful. There was a study that was done that said up to 42% of all imaging studies submitted for secondary interpretation to a tertiary pediatric care facility were found to have discrepancies from the initial interpretation. 22% of those were considered to be major discrepancies that impacted care of kids. And then gaining the child's trust, cooperation before, throughout, which can be especially difficult when our kids are struggling and are sick and are in pain. For consequences, like I kind of talked about a little bit, the false positives and the unnecessary additional imaging that sometimes these kids end up undergoing. The psychological stress from repeat imaging, a lot of times these kiddos get so used to having to go and get picked on and prodded because they end up having to get these repeat imagings. They end up separated from parents, especially like in the ED when they're kind of going around to get CT scans and things like that. So there's just a lot of other stresses that kind of come with it too. Again, we kind of talked a little bit about the associated risk with sedation. And then there's a pretty notable increased healthcare costs for families in the healthcare system. And we'll talk a little bit about it on the next slide. And then the increased risk of development of cancers due to radiation exposure, especially with repeat imaging. So with regards to kind of increased healthcare costs, the America's Health Insurance Plans, which is a trade group that advocates on behalf of like private insurers, so a little bit of a biased group of humans, but they published a report in 2009 that asserted that billions of dollars were wasted every year on unnecessary or duplicative imaging studies. And they kind of looked at cases from 2000 to 2006 and Medicare expenditures for CTs, MRIs, and then nuke med scans like PET scans. And they noticed that it rose from $3.6 billion in expenditures to 7.6, which is about a 17% year on average increase. And they really looked into, were these tests necessarily required or necessary for these patients? And a lot of them were not. And then in a report from 2016 that was in an AAP release, 9.6% of children in a sample of about like 4.4 million commercially insured children received one of 20 low value services during that year, which resulted in $27 million in spending. And $9.2 million of that was paid out of pocket, which is about 34%. 5 of those like low value tests were imaging related, whether that was getting CT scans in first time seizure kids that were like clearly febrile seizures, or getting imaging and headaches, getting facial imaging and sinusitis, which we all know is not very helpful. And so 5 of the 20 were imaging related, and some of the other ones were like viral testing, if it's not going to change management, inappropriate antibiotics, steroid, albuterol use, things like that. So repeat imaging and inappropriate dosing. So a lot of times when these kids come in from a trauma, they will sometimes get imaging studies done at the prior facility. And as all of us that have rotated in the ED, a lot of times we either can't see the images and can't get a hold of them, or the quality of them is not adequate to really be able to interpret. So a lot of those kids actually need repeat imaging. And so one study found that 27% of imaging studies were duplicated within 4 hours of arrival to the level 1 pediatric trauma center. A lot of those were CTs of the head. It was a study that was a 3-year retrospective cohort study at Tufts Children's Hospital in Boston. And they had 262 patients and 413 scans, and 67% of them met criteria for immediate transfer without a CT scan, and 30% of those were duplicated within the 4 hours of showing up to the ED because of either GCS scoring or inappropriate studies, or just weren't able to adequately interpret it to take the best care of the kid. There have been several other similar studies done at other programs, Rainbow Babies in Cleveland, American Families Children's Hospital, which is University of Wisconsin in Madison, did similar studies that showed really similar results, that a lot of times these kids are getting imaging studies at these outside facilities that are usually adult and children focused. And then they end up transferring to the pediatric trauma center and end up needing repeat imaging. And then a lot of the studies also indicate that the referring facilities, whether that's in like a smaller town or wherever these kiddos are coming from, end up using higher radiation doses for the CT imaging compared to dedicated children's hospitals that only image kids. And there was a study that said basically 51%, as far as like dose, the dose that kids were getting at these like outside facilities was about 50% of what the adults received, which was anywhere from like 6.1 to 12 units, when they really should be getting like 4. And so these kids were getting anywhere from 1.5 times to 3 times the appropriate radiation dose for their size and their age. And then this is kind of a graph that shows, this includes both pediatric and adult imaging. And this is the data from 2009 to 2018, which is the most up-to-date like cohort of reviewing radiologic exposure and imaging for internationally. And so if you kind of look at so that's like the based on the imaging itself, what do we image most? And then which x-rays, things like that are kind of what we do most frequently. And so despite the fact that CT imaging is about 10% of the imaging that's done internationally, it makes up about 62% of the radiation exposure of the general population. The US also makes up kind of a disproportionately large number of medical radiation procedures. So while the US makes up about 4.4% of the world population, we have 15 to 30% of the medical radiation procedures in high income, kind of regardless. They really they made sure to look at all of these like high income places, because a lot of times, obviously, like in the US, we're like a higher income nation. And so they looked at places like France and Italy and all of these high income nations. We still do imaging and use more radiation than anybody else does. And then this next one I thought was really interesting. And so this is US number of procedures done. And so you can tell based on like internationally, we do a lot more than everybody else does. And then if you look at B, this is the amount of radiation that we use per person compared to international averages. So we use quite a bit more radiation per person than globally people do. And the way that they looked into this was really looking at the effects of radiation on specific tissues. And whoops, this is why I can't have nice things. And we're able to kind of based on the effective dose for the different tissues that these individuals kind of were exposed to. And so now we'll kind of talk about radiation and cancer risk. This has been a very highly studied topic for quite a while at this point. Much of our kind of initial understanding about the risks of exposure to ionizing radiation were based on the lifespan study of the survivors of the atomic bombing of Hiroshima and Nagasaki. It was really deemed that children were more sensitive to the negative effects of radiation, in part due to their kind of radiosensitivity of developing organs and tissues, and then the longer expected lifespans of these kids that increased their kind of window of time to really manifest those negative radiation-related effects. So the lifespan study was a prospective cohort study. It's still kind of going on, and kind of case control study that followed a group of 120,000 subjects. 94,000 of them were atomic bomb survivors, and then 27,000 of them were unexposed individuals from the same areas. And they found an excess of leukemia cases that started about 2 years after the bombings and peaked kind of 6 to 8 years after exposure, and then kind of fell pretty quickly after that. The risk was higher among those exposed at younger ages. So the younger that these kids were at the time of the bombing, the more likely they were to have the negative effects of radiation. And then the risk of solid cancers started increasing about 10 years after the bombing and continues to be high to this day. And so this is kind of the graph of what they have noted so far with the patients that were exposed to the radiation of the atomic bomb in Hiroshima and Nagasaki. There have since been a lot of additional studies that look more into low dose radiation as opposed to atomic bomb level radiation. And so there was this was one of the first cohort studies that was done on low dose radiation with like CT scans and imaging. And so this really examined the malignancy risk associated with those like lower doses of radiation. The cancers that they kind of looked into mostly were ALL, AML, myelodysplastic syndromes, gliomas, meningiomas, schwannomas. And then they made sure to include a 2-year lag for the development of leukemia and then a 5-year lag for the development of brain tumors to kind of eliminate that bias of were they already kind of developing this and then the radiation just happened to be at the same time frame. And so they kind of removed that variable from it. And so they evaluated about 350,000 patients that had no prior history of malignancy and underwent their first CT scan between 1985 and 2002, and everyone was less than 22 years of age. And then the data was collected in the National Registry through 2008, and then either at the time of death or the patients, or if they were lost to follow up. The goal was really to further assess the risks of developing leukemia and brain tumors. And the endpoint that they were greatest concerned with was red bone marrow and brain, with them being highly radiosensitive tissues, especially in childhood. And they reported triple the risk of developing leukemia with exposure to greater than 30 units and then developing a brain tumor with greater than 50 of radiation. They really determined that it was kind of cumulative. So these kids that are requiring repeat CT imaging are noticing more of these deleterious effects because of the kind of cumulative effect of radiation. And then there have been several like meta-analysis and other studies that have been done. There was one that was released in 2020 that really looked at 26 of these studies kind of all together. And the studies that were evaluated were published between 2006 and 2017 and included 91,000 solid cancers and 13,000 leukemias. And they really found clear evidence that there is an excess cancer risk with low dose ionizing radiation. 17 of 22 studies showed increased risk for solid cancer, and 17 of 20 studies showed increased risk for leukemia. There's a newer study that they've said kind of what the study is, but none of the data is out yet. And it's the risk of pediatric and adolescent cancer associated with medical imaging. And so the goal of that is to quantify the association between that cumulative radiation exposure from either fetal and or childhood medical imaging, and then what that subsequent cancer risk is. It's poised to be one of the largest studies addressing the risk of childhood cancer and adolescent cancer associated with radiation. And they're expecting to be able to really give you that like estimated dose of like the individualized patient like organ dose and how much that affects their risk of developing cancer. The last they talked about it was in 2022. So I think they're still doing a lot of data collection with how large the study is. And then this is another study that was done, the pediatric nuclear medicine exams and the risk of neoplasm with that. This was a retrospective population-based study of Taiwanese residents under the age of 18. And it ran from 2000 to 2017, and it was designed to kind of evaluate the association between nuclear med scans and subsequent risk of neoplasm. They did eliminate a lot of the PET scans because of the bias of getting PET scans in patients that already have cancer. And so they kind of adjusted for that, and they really collected data from their kind of national registry to figure out what is our kind of cancer risk from repeat nuclear med scans. And so this is just kind of a little bit of the descriptor of kind of what they did. So for every one patient that got repeat nuclear med scans. They picked 4 matched equivalents for like age, sex, index year, all of those things to evaluate against. So they ended up with 35,000 patients that had received nuclear med scans, and then 140,000 controls that were selected that were unexposed to kind of see what the kind of diagnosis and what the outcome was. And they noticed a pretty clear cumulative incidence rate of neoplasms if they were exposed to nuclear medicine scans. And so the cancers that they looked into most were leukemias, lymphomas, and then malignant brain tumors, which represent about 70% of all childhood cancers. And it really showed that with repeat scanning and with additional incidents of nuclear med scans, and the more they were exposed to the radiation, the more likely their risk of developing cancers was. And so now we'll kind of go into some of the places that we get imaging that we don't necessarily need to get imaging. What are kind of those indications for why we should, and what are the risks of getting them if we don't need to. So the AAP introduced evidence-based clinical guidelines in 2006, which were then revised in 2014. And in both of those clinical guidelines, they recommended against the use of x-rays in patients that have typical bronchiolitis. A recent systematic review and meta-analysis looked at 32 different international clinical practice guidelines, and all of them said, don't get chest x-rays in patients with bronchiolitis. Typically, when we get a chest x-ray, as a lot of us know, in a kid with bronchiolitis, it's very nonspecific. You'll see like peribronchial infiltrates, hyperinflation, atelectasis. A lot of times, depending on who's reading the imaging, this can be misinterpreted for pneumonia, and sometimes these kids will end up on antibiotics. And it doesn't actually show, despite the fact that this increases the treatments for these kids, it shows that there's no actual improved outcomes with getting an x-ray and starting medications. And so like, despite the introduction of these clinical guidelines, there has been very little change that has been made in the clinical practice, with a lot of variation, and approximately like 545 million in direct expenditures without any change or improvement in the management of bronchiolitis. So when we think of like typical bronchiolitis, as most of us know, this is kind of the kid that has cough, respiratory distress, wheezing, crackles. It's really variable. The kiddo coughs and the wheezing changes, the crackles changes. And it's really that space where we don't have really distinct findings. And so we see this really most frequently in kids like 3 to 6 months of age. RSV accounts for most cases of bronchiolitis, but we can see it with really any viral illness. And these kiddos end up having like the increased mucus production, edema, plugs in their kind of bronchioles, which can often look like pneumonia if not read by kind of a pediatric radiologist. These kids often, after chest x-rays, will end up on antibiotics. So a prospective cohort study from a tertiary care emergency department and the hospital at the Hospital for Sick Children in Toronto noted that when these kids were imaged when they had bronchiolitis, they ended up with the diagnosis of bacterial pneumonia and increased antibiotic use from about 2% to 15%. They also noted that chest x-rays were really over-obtained in kids with bronchiolitis, especially at kind of combination centers. And they estimated for every 133 children with typical bronchiolitis, they would all have to undergo an x-ray for one person to have an imaging that suggested that there was maybe something else going on. There was another like international multi-center cohort study that included 2,400 infants with typical bronchiolitis in 38 pediatric emergency departments across 8 countries. It was North America, Europe. You can kind of see them at the bottom part of that. And they made sure to include patients that did not require intensive care or additional like significant intervention. And they found when chest x-rays were obtained, which was in about 23% of patients, antibiotics were significantly more likely to be given independent of disease severity and fever. So if they got a chest x-ray, even if it looked exactly like a kiddo that did not get a chest x-ray, it did not change the disease severity or anything of the child. And the kid just kind of frequently received antibiotics that they didn't necessarily need. So in the US, we use more antibiotics than anybody else. I know we're all shocked. Canada was next at kind of like 8.2%, and then it kind of decreased as you kind of see down the line. Reducing chest radiographs and bronchiolitis. So there was a QA project that was done at Monroe Children's Hospital in Nashville, Tennessee, with the goal to really reduce the amount of chest x-ray use in kids under 2 with the primary diagnosis of bronchiolitis. When they first started, about 42% of kids with bronchiolitis were getting chest x-rays, which is a lot. And their goal was really to get that below 15%. They included like all cases of bronchiolitis over the course of 8 years, those seen in the ICU, acute care, and in the emergency department between 2012 and 2020. They had a little over 12,000 bronchiolitis encounters. And they tried multiple different interventions. They're kind of low reliability interventions were like educational campaigns, just kind of different teachings, and they noticed very minimal change with that. And then they kind of switched over to more high reliability interventions, like removing the chest x-ray from the order set for these kids that are coming in with first time wheezing, or putting in a best practice advisory saying, are you sure you want to order a chest x-ray in this kid? And they noticed really sustained changes over the last 4 years. So you can see kind of on the left side of the screen, that was kind of where they started at. They had tried to, like you can see when the 2014 guidelines were released, and then they tried kind of like lower yield practices as far as like education and things like that. And then when they removed chest x-ray from the default order set in their dyspnea order set in July of 2015, they noticed a sustained change from 42% down to about 23%. And then when they adjusted the guidelines again in 2018 and added that best practice advisory, they kind of got down to that sustained like 18.9% on average with regards to the number of chest x-rays that these kids were undergoing, which is a pretty notable change. So when do we x-ray these children? And so there was a Choosing Wisely campaign through the AAP, which its goal was to kind of promote conversations between clinicians and patients about what tests, treatments, and procedures were needed, which ones were not. This was discontinued at the end of 2023, but they really emphasized the importance of not obtaining chest radiographs in kiddos with bronchiolitis, croup, asthma, or first-time wheezing. Times to get a chest x-ray. If sometimes these kiddos have underlying respiratory or cardiac disease, history of prematurity, significant hypoxia, focal abnormalities concerning for pneumonias, high suspicion for pneumonia, that really prolonged course of illness that is not following what we would expect to occur in a typical bronchiolitis case. Kids that are immunosuppressed, or patients with really significant and severe respiratory distress, to make sure that there's not any additional things that we kind of are missing in those scenarios. So we'll talk a little bit about constipation. As we know, constipation is a very common thing that we see in patients really all over the hospital, inpatient, ED, outpatient. We kind of talk about it all the time. Abdominal radiographs are fairly commonly obtained in the evaluation of constipation. And there are several guidelines that were released that says why. The North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition, and then the European equivalent, they released evidence-based guidelines in 2014, and they really had 9 clinical questions addressing the diagnostic, therapeutic, and prognostic topics that were related to constipation. And one of those was the kind of diagnostic value of these tests that we do. The diagnostic tests that they kind of talked about were digital rectal exam, abdominal x-rays, colonic transit time, and then transabdominal rectal ultrasounds. And evidence really supports not using abdominal radiography to diagnose functional constipation, as it is a diagnosis, like a clinical diagnosis, and not necessarily something that we need to get x-rays in. So what they looked a lot into the sensitivity and specificity of abdominal x-rays in patients with functional constipation. And there was a historical cohort study of kids seen in Detroit. And then over a 3-year period, about 1,400 x-rays were performed in about 1,100 patients. The sensitivity in the diagnosis of constipation was about 74%. The specificity was about 27%, positive predictive value 46%, and the negative predictive value of 54%. And so the study really demonstrated that it's not a very reliable means of diagnosing constipation. And all the evidence really points to it's not super reliable and not something that we should kind of continue to expose kids to if it's not necessarily going to change management. There was a cross-sectional study of pediatric emergency medicine providers in 2019, and they basically surveyed the PEM providers, and they said plain radiographs were viewed as either somewhat or minimally like value added to the evaluation of constipation. And as all of the residents that have rotated in the ED know, obtaining family buy-in was about 50% of the reason why abdominal radiographs were obtained in the ED, which I think is not an uncommon thing in the outpatient setting either. We've all seen abdominal pain that's super significant, and parents are very worried that something else is going on. And despite our clinical judgment that they really are kind of struggling with constipation, sometimes families really require or they think they require proof that there's nothing more significant going on. So there's different abdominal x-ray scoring methods, colonic transit time, Leach, and Bar. The Leach really divides the abdominal radiograph into 3 segments: the right colon, left colon, and the rectosigmoid colon. And then there's numbers and scores based on the volume of stool in those areas. A score greater than 9 was considered positive for the Leach score, and a score greater than 10 for the Bar score. The amount and consistency of it was really a difference in the Bar versus the Leach, and then the Bar has 4 different areas that they pay attention to. While this might provide a more reliable and objective evaluation of abdominal x-rays, it's not routinely used by us or by radiologists. There's a ton of like inter-observer variability, which makes it kind of unreliable, and there's a real lack of reproducibility. They've tried to look into these scoring methods kind of more universally and widely used, and haven't been able to support the validity when used in like really broad settings, really based on the kind of variability between individuals as they're reading them. One of the big things that I noticed when I was looking into this is the concern for misdiagnosis in patients that get abdominal radiographs for constipation. So a multi-center retrospective cohort study that included 282,000 children diagnosed with constipation found that the kids who received abdominal x-rays were about twice as likely to return to the ED with a clinically significant alternate diagnosis. The most common misdiagnoses were acute appendicitis and intussusception. And x-rays were performed more frequently in misdiagnosed children, and both groups had very similar amounts of stool on x-rays. And so what they really found was that these patients had abdominal pain, things weren't getting better, family needed that kind of reassurance, and they got an abdominal x-ray. They noted stool, and then once they saw stool, it was, okay, they're constipated, and those other differentials kind of fell to the wayside. And then the kid kind of clinically presented themselves as an intus or an acute appendicitis. And so there's always the concern of, we're getting this test despite the fact that constipation is a clinical diagnosis, and it may cause us to miss more significant etiologies. So when we think about how we should diagnose constipation, so there have been several releases of the Rome criteria for chronic constipation. And so this is the most recent criterion. It's the Rome 4 criteria for chronic constipation. They have to have at least 2 features for at least 1 month in infants up to 4 years of age. And it's 2 or fewer stools per week, history of excessive stool retention, history of painful or hard bowel movements, history of large diameter stools, presence of large fecal mass in the rectum. And then in kiddos who are toilet trained, there are 2 additional criteria that can be used. And it's an episode of fecal incontinence once per week after being toilet trained. And then that history of large diameter stools that kind of may obstruct the toilet. When kids say they don't look, they do too. And so then we'll talk now a little bit about P-CARN scoring. There were 2 things that came out recently. There's new cervical spine P-CARN guidelines for when we should CT a kiddo with a cervical spine injury after a blunt trauma. And then there was an additional study that was done to kind of revalidate the other 2 P-CARN scorings that we have for intra-abdominal injury with blunt trauma and head imaging with blunt trauma to look for TBI. So approximately 8 million children in the US are evaluated in the emergency department following blunt trauma. About less than 1% of those are diagnosed with cervical spine injuries. A lot of times these kiddos will have CT scans obtained to evaluate for cervical spine injuries, which, as we know, exposes them to radiation that may not be required. And there was really no criteria that was universally accepted for when do we CT these kids and when do we not. It was really kind of clinician judgment and was obviously very variable. So a population study was conducted and developed to validate a prediction rule or prediction tool to better identify the kids that were at highest risk for cervical spine injury after blunt trauma, and then subsequently minimize the unnecessary radiation that these kids were getting. So it was about 23,000 children who experienced blunt trauma and were evaluated in 18 emergency departments affiliated with the P-CARN network. About 1.9% of those kids were found to have cervical spine injuries. And they kind of identified between those kids and the additional patients that did not have cervical spine injuries, what are our high risk and intermediate risk factors that kind of help identify and help with medical decision making to minimize CTs and X-rays in these kiddos. And so this is their kind of prediction rule guideline. So GCS scoring of 3 to 8 or AVPU. And so AVPU is alert kind of responsiveness. So are they alert in general? Are they able to be aroused by voice, able to be aroused by pain, or are they unresponsive when you try to interact with them? If they have kind of abnormal airway, breathing, circulation, or focal neurologic deficits, then in those cases, those are kind of our high risk kids that we should consider getting a CT in to rule out cervical spine injury. And then our kind of intermediate risk group would be the GCS of 9 to 14 or like other signs of altered mental status. Yeah. So not completely alert, they're responsive to voice and to pain, but they're not really alert and interactive. Self-reported neck pain or neck tenderness on exam. As those of us that have been in the ED, this is very variable, and a lot of people are like, ow, my neck hurts. And so it's kind of a more subjective one. And then really substantial head or torso injury. So when they talk about substantial injuries that define kind of warranting observation or intervention, were skull fractures, if they had a pneumo, signs of solid organ injury, thoracic, lumbar, or sacral spine fractures or pelvic fractures, really telling us that this was a more significant mechanism of injury and not just like a simple whiplash injury or things like that. And then if they didn't have any major risk factors, really kind of consider clearing their C-spine and not obtaining further imaging. And so the data really suggests that this has the potential to really minimize the amount of CTs that are obtained for cervical spine injuries and subsequently decreasing the amount of radiation that these kids are exposed to unnecessarily. And then the P-CARN intra-abdominal injury and thoracic brain injury prediction rules, those were released forever ago. And so just to kind of revalidate them and to kind of reassess, are these still good rules? Do they still really have a clear picture of these are the kiddos that we need to worry more about, and these are the kiddos that we don't. A prospective validation study from several emergency departments in California and Texas. They evaluated between 2016 and 2021. And they evaluated about 7,500 kids with blunt abdominal injury, and almost 20,000 children with minor head trauma were enrolled in the study. The intra-abdominal injury and the traumatic brain injury rule for children less than 2 both had sensitivities and negative predictive values of 100%. So pretty valid. The traumatic brain injury rule for kids older than 2 had a sensitivity of 98.8% and a negative predictive value of 100%. The 2 children that were missed were admitted to the hospital, monitored, and did not require any additional neurosurgical intervention or treatments. And so really they found that these rules still were valid and had a high degree of accuracy in obtaining imaging in the children that needed it, and really minimizing the use of it in patients that didn't. And so there have been several initiatives that have come out over the years that kind of have been working to decrease the number of unnecessary imaging and really optimize imaging strategies, both for the healthcare system and for the best care of our patients. I talked a little bit about the Choosing Wisely campaign a little bit earlier. And the reason for kind of the discontinuation was other ventures. They're not super clear about it. But it ran for 11 years, and there were several different things that were released. There was an emergency medicine and inpatient one that kind of talks about and antibiotic use. So there were several subspecialties. You can still see their like Choosing Wisely like campaign sheets, but the actual site is closing down, I believe, in December of this year. The ACR they developed kind of imaging guidelines, which is the American College of Radiology. They developed imaging guidelines and appropriateness criteria from evidence that's kind of periodically reviewed by kind of multidisciplinary panels for many pediatric conditions. And it kind of provides appropriateness ratings and relative radiation risks from the imaging studies. I don't know if it'll actually let me open this. And so this is like seizures in kids, and really kind of following, this is when it's appropriate. Oh, you can't see it on your side. It's okay. But it really has, there's like a green zone, yellow zone, and red zone. So like it's usually not appropriate for it in this case. So one of the variants, neonatal seizures, age 0 to 29, MRI head IV with IV contrast, and really says that like CTs are really not appropriate in this age range, and really kind of goes through the different age ranges and the different imaging studies. When is this appropriate and when is this not? How do I get back to that part? So I can't have nice things. And so how do I do that? And then how do I see my screen again? And so then there's the Imaging Gently and the Imaging Wisely campaign. The Imaging Gently campaign was an alliance that began kind of within the Society for Pediatric Radiology in 2006. And it was kind of developed in 2007 with the goal to raise awareness of the opportunities to lower radiation doses in the imaging of kids by really providing information and free educational materials, both to the members of the care team as well as to the parents, so that they can advocate for their children. And then the Imaging Wisely campaign was a joint narrative between the American College of Radiology and several different radiologic societies to provide information to the medical community to really promote the safety in medical imaging. It was started in 2010 with the objective to lower the amount of radiation used in medically necessary imaging studies, and then obviously eliminating unnecessary imaging and unnecessary procedures. The ACR guidelines have several different imaging guidelines that you can find very easily online. They talk about head trauma, headache, osteo, seizures, pneumonia, appendicitis, what studies are validated, what studies are most helpful in these cases to really minimize the amount of inappropriate imaging and get the kids the care that they need. And so this was something that I saw too, really kind of 4 questions whenever you're considering an imaging procedures. Has it been done? There have also been a lot of studies that talk about repeat imaging between due to poor communication or poor online transfer of imaging studies. So has it already been done? Do I need it? Is it going to change what I do for this kid? Is it going to strengthen my confidence in the diagnosis? Sometimes, yes, but do you need to strengthen your confidence in the diagnosis? Is this something that I need emergently? Is this something that I need now? And if I do need imaging for this patient, is this the best clinical imaging? Is this the best test for this kid, or are there alternatives that I can use that don't subject these kiddos to radiation? So when we think about like the appendicitis guidelines, instead of jumping straight to CT, get an ultrasound. If the ultrasound and physical exam are inconclusive, then kind of proceeding to a CT scan if necessary, but not jumping straight to those studies that subject these kids to radiation. And then there's also it's called ALARA, ALARA, and it's as low as is reasonably achievable. And so it's kind of guidance that has come out and has been kind of adjusted both for patients that are receiving imaging studies as well as us who are around these kiddos or kind of our radiology technologists, and kind of the guidance for radiation safety to avoid exposures if they're not necessary, with kind of those 3 protective measures of time. So the minimum amount of time in the machine or around the radiation, kind of distancing, and then shielding and wearing lead in those situations to protect yourself. And then I have 2 pages of resources.
Yeah.
Yes,
First, nicely done.
thank you.
A lot of good data and help. And it's definitely more important than radiation studies, but we see it with all kinds of great example of that. Our pediatricians around here are a whole lot better about not just ordering it. Some people are not so good at that, but it's thousands of dollars for a benign test. But yeah, there should be clinical judgment, whether it's chest pain or palpitations, whatever. Ask the right questions, come to a diagnosis.
Yeah. And then sometimes you find those incidental findings that aren't actually clinically relevant to the kiddo, and then they need all of these additional things that aren't necessarily needed for the kid. I also saw some stuff on like cardiac interventional and trying to minimize the radiation that kids are getting for like PDA closures and those pieces when they're getting those kind of longer interventional radiologic procedures and studies.
We just had, nice job. We just had a SPAR come out organizationally about how our scanners are running behind, right? And so just reminding us all that using our clinical tools, using a good exam, maybe referring to an expert before jumping to the advanced. So, I mean, they were talking about CTs and MRIs, but I also think about if I'm clogging the scanner up with somebody who maybe doesn't need an image, I'm delaying somebody who might have a more urgent diagnosis and potentially harming not just my patient with unnecessary time and cost and potentially radiation, but some other patient as well.
We also see it in the hospital if a patient was transferred and we're supposed to have images already done, but they were not available for us to review. Those are always tricky because you want to like either confirm it if the patient had already been started on antibiotics, you wouldn't probably hear anything on exam or see the findings, but you still want to confirm that you are still treating appropriately. Those are difficult, I guess.
Yeah, and I think sometimes we get in the habit of doing all of the pieces to figure out how to get said imaging is a lot more work than just clicking the button and ordering the imaging and having it done and read by people who you know look at all of these imagings and who you trust to really look at the imaging appropriately and give you that information. So I think looking into this too, when I was like looking at constipation, I don't think we order x-rays a lot in constipation, and I feel like a lot of it is really, we can't how do we get parents from point A to point B in these situations? So really working to try to get them to a space where really voicing and making sure that they completely understand the risks of the test, and not just saying, okay, if that's like what you need, but really making sure that they have full understanding of why you don't think that it is clinically necessary, the risks of getting it, and kind of those other pieces of it too.